In 2022, WHO published new guidelines that included a new interim conditional recommendation on the use of treatment decision algorithms for tuberculosis in children. As these new recommendations were interim and conditional, WHO also called for generations of evidence through research studies to externally validate the new treatment decision algorithms and inform a future review of the recommendation. The TB AlgoPET is a multi-country study to assess these new treatment decision algorithms for tuberculosis in children. The primary objectives of this study are to assess the diagnostic accuracy and the diagnostic cascade of the new treatment decision algorithms for tuberculosis in children, and to assess the feasibility and acceptability of implementing these new algorithms. The study has also some secondary objectives, and today we are presenting TB case notification rates prior to and following the introduction of these algorithms. Here are the two treatment decision algorithms for children less than 10 years of age with symptoms suggestive of pulmonary tuberculosis. Algorithm A is for contexts with access to chest X-ray, and algorithm B is the same but for contexts without access to chest X-ray. If we now focus on the first part of the algorithm, it's the same for algorithm A and B. The algorithm first identifies children with a high risk of disease progression. These are children less than 2 years of age living with HIV or with severe acute malnutrition, and these children should be investigated immediately for tuberculosis. If the child does not meet these conditions, then it can be treated for the most likely non-TB conditions and in follow-up in 1 or 2 weeks. The algorithm includes GeneXpert and TB-LAM when available, and also the history of a contact with a person with TB. Then the second part of the algorithm is a score that is based on signs and symptoms of tuberculosis and on the findings of the chest X-ray for algorithm A, and on signs and symptoms of tuberculosis only for algorithm B. If the sum of this score is more than 10, the algorithm recommends to treat for TB, and if not, to review the patient in 1 or 2 weeks. The TB AlgoPET study is a multi-country study with 3 components: a prospective diagnostic study, an analysis of routine program data, and a mixed method study. For the first 2 components of the study, the population are children under 10 years of age with signs of symptoms of tuberculosis. And for the third component, the mixed method study, the population are health workers, policymakers, program managers, key informants, and caregivers. We have conducted this study in 5 countries: Nigeria, Niger, Guinea, Uganda, and South Sudan. Let's start by the prospective diagnostic study. The procedures of this study follows the algorithm that I have just presented. So first, a medical history and a clinical exam, then a GeneXpert and a TB-LAM when these tools are available, a chest X-ray if the chest X-ray is available, and then the score based on clinical or clinical and radiological signs. Then, if indicated, there is a follow-up visit at 7 to 14 days. And as part of the study for all children, we had a follow-up visit at 2 months systematically. This slide shows the characteristics of the population. We included 1,613 children, and you can see in the first column that the median age was 1.7. 72% of the children were severely malnourished and 10% were living with HIV. If we now look at the other columns, we can see that in each country, we focus on specific populations. For example, in Guinea, we focus on children living with HIV and all were ambulatory. Nigeria and South Sudan included mainly children hospitalized and mostly severely malnourished. And Uganda, it was most a mixed population with both hospitalized and ambulatory, 22% severely malnourished and 6% living with HIV. Among all children included in the study that were children with symptoms and signs of tuberculosis, 27% were diagnosed with TB and treated and started on TB treatment. And you can see in the graph on the right that most of these children were started on TB treatment at the initial assessment within 1 week. Now let's look at the reasons, the main reason to start TB treatment, to diagnose the children among those that were diagnosed with tuberculosis, so 498 children. If we follow the algorithm steps, starting by gene expert and LAM, we can see that among these children, 7% were expert positive and 6% were LAM positive. For 19% of the children, the main reason to start TB treatment was the contact with a person with TB. And for 70% of the children, the main reason to start TB treatment was the clinical or the clinical and radiological score. We also look at the diagnostic accuracy of the new algorithms, and these are interim results in part of the population, 1,354 children. We assess the sensitivity and specificity of the new algorithms versus a reference standard that was based on the international consensus case definitions for intrathoracic TB in children, and we found that the sensitivity was 91% and the specificity 87%. And now Emily will continue with the rest of the presentation. Thank you very much.
I can just continue as the slides are loading. So as Helena mentioned, the second pillar of our study was an analysis of routinely collected data. And to do this, we took data looking at the health facility registers and the TB registers in each of the sites. And from these, we extracted the number of admissions or consultations that were conducted in each site, as well as the number of children who were put onto TB treatment. And so for this part, we can go back one slide. So we looked at the number of children who were initiated on TB treatment, and we looked at this for a period of about 1 year before and 1 year after the algorithms were implemented in each site. And then we took this data and we conducted a multivariate interrupted time series analysis. And this analysis model was adjusted for several factors, including whether or not the algorithm had been introduced yet. It was also adjusted for things like whether or not it was peak malnutrition season, the time since the algorithm had been introduced, and it was also adjusted by country site. And the results of this analysis are shown here. And we can see that each dot on the slides represents the proportion of children that were admitted or consulted who were initiated on TB treatment. And the unshaded area on the left of the slide is before the algorithms were introduced, and the shaded area on the right of the slide is after the algorithms were introduced. And we can see that in general, across each of the sites, the proportion of admitted or consulted children initiated on TB treatment tended to increase after the algorithms were introduced, which is what we would expect. And this is further illustrated through the blue lines on each graph, which were generated through the model. And the model results also further reinforce this trend, as we found that on average across the study sites, the proportion of admitted or consulted children initiated on TB treatment more than doubled after the algorithms were introduced, with an effect size of 2.23, and this was statistically significant. The third pillar of our study was the feasibility and acceptability study, which we conducted using a mixed methods approach. This included focus group discussions with healthcare workers, as well as semi-structured interviews with key informants, caregivers, and healthcare workers. And these discussions were then analyzed thematically and through critical discourse analysis. And for our presentation today, we'll focus mainly on the results of the discussions with the healthcare workers. In discussing with the healthcare workers around their experience using the algorithm, we found several positive results around their experience. The healthcare workers shared that using the algorithms in general helped them to speed up their processes and increase their TB diagnosis. The healthcare workers also felt that using the algorithms helped to increase their autonomy, especially in healthcare centers that had few resources. The healthcare workers often noted that using the algorithm helped to enhance their professional skills, and this was often associated with the training that accompanied the introduction of the algorithms. And overall, healthcare workers found that using the algorithms was efficient, the algorithms were easy to use by all types of staff, and the algorithms were helpful and accessible and acceptable. And we can illustrate this with a small quotation from a healthcare worker in Uganda who shared, "I feel there are some advantages in the way that it, the algorithm, will guide the clinician who is going to diagnose, to make a rational diagnosis." And of course, as with almost any intervention that you could introduce into a healthcare setting, there were some small challenges that were identified. So some healthcare workers identified that they felt that when using the algorithms, they felt their workload increased, and this was often tied to the idea that when using the algorithms, they felt their consultations took longer. The healthcare workers also identified that it was very important to have a high quality of communication with the caregivers when using the algorithm. And this makes sense because, as Helena explained when introducing the algorithm, it's important to know when using the algorithm whether or not the child has a history of contact of someone in their household living with tuberculosis. And it's also very important to know the exact number of days that the child has been dealing with each symptom in order to calculate the symptom score. So of course, in order to get this detailed level of information, it makes sense that the healthcare worker would need to gain some trust and spend some time discussing with the caregiver. And we have a small snippet of a discussion of healthcare workers in Niger to help illustrate this point. These healthcare workers share. Because when you ask a mother about the big cough, she doesn't even know what it is. She doesn't even know what it is. Tuberculosis, yes. And secondly, she thinks she'll be stigmatized. Even if she knows there's someone who is suffering and is being treated at home, she's not going to tell you that easily. So, from the results of these three pillars of our study, the diagnostic accuracy study, the analysis of routine data, and the feasibility and acceptability mixed method study, we have a few conclusions we'd like to share with you today. First, we found that the diagnostic accuracy of the algorithms was high, and most children who were diagnosed with the algorithms were diagnosed at their first assessment. We also saw that the clinical and clinical radiological scores were very useful elements of the algorithm for diagnosing TB. We found on average a twofold increase in TB treatment initiation across sites after the algorithms were introduced, and we found the algorithms were well accepted by health workers. They provided autonomy and facilitated TB diagnosis in children, particularly in health facilities with less skilled staff and those offering ambulatory care. We're very pleased to share with you that so far we've seen the study implementation and results are already helping to support the algorithm used by MSF and ministries of health in the study sites, as well as in other sites in countries around the world. We have found that the feasibility and acceptability results can assist in tailoring site-specific implementation. And we've also found that as the algorithms are introduced and more children are put on TB treatment, it's very important that the corresponding TB drugs are planned for from the beginning. We hope that the evidence generated from this study will inform the WHO review of guidelines planned for 2026, and we also anticipate further research on specific aspects of using the algorithms, such as in children living with HIV and in settings with a high prevalence of malnutrition. This work would not have been possible without the study participants, our entire research team, and our partners. Thank you.